Society of Cardiology, of course.
Okay, just to let you know that I am recording the session. And please, if you can go on mute, we'd appreciate it. Thanks.
Great, thank you very much, Sophia. Okay, so by default, my colleague Sophie will try to place your microphones on mute, but please keep in mind that if you are switching between a speaker and the headset and the mobile and so forth, your Zoom might put you out of mode and make your mic and eventually even your camera active. So please, for your own privacy, make sure that you are always on mute. So to maintain your privacy. Okay, again, thanks again for joining. Good afternoon, good evening, wherever you are. My name is Jawdat Sanuri. I'm the product manager for cardiac ultrasound, cardiovascular ultrasound from GE Healthcare across emerging markets. ACE, again, is our advanced courses in echocardiography educational program aimed to foster the implementation of the advanced echo tools such as strain, AI, new tools, automated tools, quantification tools, as well as for the, of course, one of the main focuses for the echo navigation, cropping, as well as for the quantification. So last Thursday, we spoke about the basic principles of 4D echo acquisition as well as navigation. And we promised today in this session for the echo, we will talk more on the quantification. We will breeze through some of the basics when it comes to 4D, of course. The basics of 4D, the fundamental core of 4D is having the 4D probe, of course, that can have the matrix array in order to scan a volume, a pyramid-shaped volume that can go up to 90 degrees by 90 degrees. And of course, this is powered by advanced processing, CPUs mainly inside the probes, whether it's transthoracic, adult, pediatric, or even transesophageal, or even in the future, who knows, there might be 4D transesophageal probe capabilities in the future. And again, that all uses the matrix array technology that enable us to have what we call a one probe solution for the entire population. For example, the 4VC, this probe here, the 4VC transthoracic probe is the one probe solution for the entire adult and adolescent population. We also have a pediatric probe that is for the entire pediatric and neonatal population, where you can use it for 2D color, PW, CW, of course, spectral Doppler as well as for the cropping multi-planar, as well as for the volume acquisition, in addition to for the volume acquisition grayscale and spectral Doppler, color Doppler, sorry. Okay, so what can you do with a 4D probe? Multi-planar imaging. We also spoke about this last week. You have the biplane capability, you have the triplane capability. The biplane or the X-plane is where you have a long axis, and then you activate the biplane. Then you will have a short axis at a selected plane level that you choose from this dotted line here. You can move it from papillary muscle level to mitral level to aortic level, select where the short axis is going to be. There's even a possibility, what we call V-planes, two parallel planes at different levels, such as, for example, two short axis planes at papillary, at aortic level at the same time, or at mitral, at aortic level at the same time, if you want to. That is also possible because it's all electronic switching of different planes at different levels, electronically selected on the probe. Then we have triplane capability, which is exceptionally or specifically more helpful in the apical views, where if you start with a normal 2D 4-chamber view and you activate triplane, instantly you will have a perfect 4-chamber, perfect 2-chamber, perfect 3-chamber. Of course, as we mentioned last time, you have to have the apex in the center of the image, the LV in the center of the image, not the septum. Immediately you will have a perfect 2-chamber and 3-chamber in addition to the 4-chamber. And you can change the angle as well, as we mentioned. Then you have the, once you have the biplane or triplane acquisition, the multi-planar acquisition, then you're able to do biplane ejection fraction or triplane ejection fraction, or even auto-AF, or even strain quantification, such as AFI, automated function imaging, as you know, is GE's tool for calculating the longitudinal strain, and ultimately, of course, GLS, the global longitudinal strain, which is the average of all 18 segments. And of course, the modified bullseye can be viewed the bullseye can be modified viewed in a modified 17 segment format as per the European as well as the American Cardiac Society's recommendations. Naturally, the use of triplane imaging enable us to acquire the 3 apical views simultaneously and live, as well as when you acquire them, they are all acquired from the same ECG cycle, meaning that there is no RR variability, hence reducing the risk of failing AFI or failing strain quantification, because in any strain quantification program, you have to have the same heart rate from the 3 views in order to reconstruct the bullseye, of course, for the longitudinal strain, and to measure the average of GLS, global longitudinal strain. In addition, you can actually perform the viremian stress echo without ever having to move the probe. You can just put the probe in the apex, and instantly you acquire 4-chamber, 2-chamber, 3-chamber, all 18 segments, and you can do for each stage, of course, baseline, low dose, peak, recovery. In addition, you can also do wall scoring for each stage, so you really never have to do any wall scoring. You can simply do the AFI for each stage, and you will get an AFI bullseye with the GLS as well as the regional or zone or coronary zone strain values, as you can see here, for each stage. So whether you're doing a viability study or a normal stress echo ischemia assessment study, you can still use AFI for each stage. So you'll have a bullseye for each stage independently. In addition, of course, we can also use the same speckle tracking technique, which we have introduced recently, which is AFI RV for the right ventricle using the 4-chamber. And again, you'll have the 6 segments, the 3 septal, the 3 free wall, and you'll have the global average and even the free wall average by itself, as you can see here on the screen, which is usually higher, of course, for normal patients, as well as the TAPSE displacement. And of course, AFI or strain for RV has been proven very critical in the last 2 years during the COVID pandemic, because of the implications of the right ventricle and myocarditis and pulmonary embolisms for COVID patients. Then we also have recently introduced AFI for left atrium, which is gives us simply the longitudinal strain. For the left atrium, it treats the entire LA as one segment from 4-chamber as well as from 2-chamber. But the advantage is here we can get the reservoir strain, the conduit strain, as well as the contraction strain from 4-chamber and 2-chamber and the biplane average. And we can even get the LA areas, diastole, systole in 4-chamber and in 2-chamber, hence giving us the LA volumes, maximum, minimum, and ejection fraction of the LA in 4-chamber and 2-chamber and biplane. This is because, again, we're talking about multi-dimensional imaging where we are able to acquire more than one plane simultaneously. When we talk about 4D, we spoke about 4D volume acquisition. Again, there's single beat, there's multi-beat. We explained last week about the difference between single beat and multi-beat. Of course, quickly, single beat is acquiring the entire area of interest, live, real time, no need for stitching. Multi-beat is where we acquire one section at a time, each heart cycle, resulting in better frame rate, better spatial resolution or voxel resolution. However, please don't forget that multi-beat always has a risk of stitching artifact if there's any motion, respiration, arrhythmias, or abnormal RR variability. We spoke about the single beat for color Doppler. Of course, it's very important to acquire a single beat for color Doppler. This is an example of multi-beat where we are seeing in the first cycle of a 6-beat acquisition. This is only the one section that's being acquired during that multi-beat acquisition. So again, to answer the question that's always coming up, and this is the answer that we always get from the experts across the field, is it better to acquire single beat or multi-beat? The answer is it's always better to acquire multi-beat if you can overcome the challenges, again, motion, respiration, and arrhythmia, of course. Then there's the 4D auto alignment and 4D automatic views, which is done once we have reference markers 4D across the volume for the annulus and the apex in 4-chamber, 2-chamber, 3-chamber. From there on, we can navigate to a 4-chamber slice of the volume of the heart, hence cutting the heart in half at the level of the 4-chamber or 2-chamber or apical long axis, using, in other words, conventional or traditional 2D cut planes, familiar anatomy and cut planes, to look at surface rendering of the remaining half or half of the heart or the structure. And you can also select valves. For example, you can select mitral valve. It will give you a cropped zoom around mitral valve, either from the ventricular side or from the atrial side to visualize. Okay. We spoke also about the importance of multi-slice. Multi-slice is simply a way to visualize the volume acquisition. We're still acquiring a 4D volume. However, we choose to display it in slice mode, like a CT or MR mode, because we want to see, do we have the full acquisition of the area of interest. This is especially helpful if I'm trying to do LV quantification or RV quantification. I need to see the rings of the LV. Is it all in from apex to base? Likewise for the croissants of the RV from apex to base. Again, there's also a flexi slice. This is a nice example of using flexi slice. This is going backwards using 4D to derive optimal 2D cut planes. Here, this is in this example, you see a left atrial appendage. You see that we have adjusted this line to get also a long axis on the left bottom corner. We have adjusted the green line here, as you can see, to get a perfect short axis for on the right bottom corner. However, you can see this angulation here is not the right place to measure to get the short axis for the long axis here on of this appendage. Once we make the adjustment, then we have now the right long axis. Hence, our measurement will be more accurate and more reliable, of course, in terms of sizing for LAA closure device, as in this case. Of course, this can be used as an adjunct to the gold standard again, which is CT in many cases for LAA appendage closure. We can also use flexi slice to measure areas such as aortic valve area planimetry. And here you can see 3 different examples where I'm using flexi slice to guide exactly where is the best place to measure the aortic valve area, which is the top right corner. On the top and the bottom left corner, you see the slice of the short axis is high up, so it's not at the right place to measure the aortic valve area planimetry. On the bottom right corner, you can see the slice is a bit low, not at the tip of the leaflets, where you can see here you are actually over exaggerating the aortic valve area, including this area of commissures between the annulus of the aortic valve. When you are scanning 2D short axis only, you're never sure, do you have the right plane, the right level, and the right angulation as well. So this is where flexi slice can also help in that kind of scenario. And even in mitral valve area planimetry, even here in assessing this color Doppler of this perivalvular leak, the area of the color Doppler. Here, this is an aortic regurg, again, measuring using flexi slice to get the perpendicular short axis, so you get the accurate aortic valve regurgitant orifice area. Likewise, using multi-slice as well, we can use multi-slice to do that. Here in this example, notice the proper angulation across the different apical views or um, 4-chamber, 2-chamber, and 3-chamber views from this TE acquisition from mid-osphageal or upper osphageal. But the important thing is that we are able to get the perfect cross-section where we are able to measure the vena contracta area or regurgitant orifice area more accurately and confidently as per the ESEVI recommendations, actually. There's also, we can also do measurements on the surface rendering itself on the 3D. However, please keep in mind that this type of measurement is actually here in this example, you have a mitral clip, and you can see here the residual mitral valve area post clip placement. Here you can see from the ventricular view, you can actually see there are 2 clips, and this is the residual area. And in the next example, I think here you can see where we measured the residual mitral valve area post clip deployment. Please keep in mind when you are trying to make this such measurement to have the surface in fossa as much as possible, because this measurement area is measured on a projected surface from this 3D volume. In other words, if it is angled, then you could easily, or you will underestimate the area of this mitral valve. This is how they do it in space, actually trying to measure sizes and the volumes of objects in space, taking that into consideration. That what we are viewing from space is actually a projected surface on the atmosphere. Okay, so in terms of quantification, you have lots of quantification tools for chamber quantification as well as valve quantification. We start with for the auto left ventricular quantification. It is very simple. You simply select 2 points, one at the apex, one at the annulus or mid-base in diastole. Likewise, in systole, you can even prompt the echo pack to do the entire quantification automatically for you. Nevertheless, whatever you do in quantification, this is something that we do in GE. With any kind of quantification, it is always semi-automated because you have to validate whatever measurement and accept it. We don't allow it to go through and process everything by itself. You have to validate and accept it. And the same way the algorithm can track the endocardium, it can also track the epicardium, subtracting, of course, the volumes, gives us the actual volume of the myocardium. Multiplying it by density gives us the actual LV mass, and that's calculated simply and easily also on the machine algorithm. There's also 4D strain, and there has been lots of discussions about 4D strain versus 2D strain, which is better. Of course, 2D strain has always the utmost advantage when it comes to speckle tracking in terms of frame rate, because 2D strain has the higher, 2D imaging has higher frame rate altogether. However, 2D always has the 2 challenges. One is foreshortening, and second, which is displacement. As in this example here, you have the short axis when you are in trying to do circumferential strain for this short axis. When you are in diastole, your line, your 2D cut plane is actually in the mid segments. However, during systole, because of the annular displacement, the annulus displacement, you are actually scanning the basal segments. So there's could be easily foreshortening or changing in the actual position that you are scanning throughout the cardiac cycle. And of course, there's a risk of foreshortening if you're doing apical views, for example, 4-chamber or 2-chamber. However, with 4D strain, we have the full speckle of the entire segment. It's not only a cut plane, not longitudinal, not short axis of the segment, but it is really the entire segment. And we have the speckle tracking algorithm is tracking this entire segment throughout the cardiac cycle, hence enabling us to do longitudinal strain, circumferential strain, and radial strain for each of the segment for the entire segment of this myocardium, not a cross section or a cut plane of this segment. So we are able to do longitudinal strain, the curves for all the 17 or 18 segments in a modified bullseye for 17 segments, of course, and giving us the GLS, the global, ultimately, of course, the most significant value is the global longitudinal strain. Likewise, we can do it for circumferential strain, for radial strain, as well as for area strain, which is a combination of both longitudinal and circumferential. And usually you'll find that the area strain is actually the sum of longitudinal and circumferential strain for each segment. Then there's RV, where in the past, we're always trying to measure everything except for the volume itself of the RV to estimate the actual RV function. And that is for the simple reason that 2D imaging could never give us a cut plane representative enough of the right ventricle where we can make geometric assumptions and can make an assumption about the volume of the RV, not the 4-chamber. There's many different levels where we can take it, where it would be different in the groove, in the tricuspid inflow. There, of course, it's even more challenging with short axis. 1 milli up or down can make a huge difference on the volume assessment, and not enough markers for that. So this is where RV quantification for the right ventricle quantification comes in, because we have the full endocardial borders of the RV within the data set, within the volumic data set. Hence, we can use speckle tracking to detect the endocardial border of the entire RV. And for the first time, not only we are able to calculate the volume, we are actually able to measure the volume right away with 4D auto right ventricle quantification, and get even a butyl of the RV and the instantaneous volume in diastole to insystole, ejection fraction, stroke volume, even TAPC and fraction area change, and so forth. And of course, the automated tool gives us some guidelines so that we can have some landmarks that we have to decide to guide the speckle tracking, where to find the endocardial border, and hence track it throughout the cardiac cycle from diastole to end systole and back. Okay. So again, just to point out the importance of multi-slice imaging. During the acquisition, we can utilize multi-slice to make sure that we have the entire area of interest. As you can see here in this example, we have the 3 apical views of the RV itself. However, more importantly, or at least a 4-chamber and 2 60 degrees apart from the RV. More importantly, the short axis from base all the way to apex. The apical short axis, of course, is the top left one. The basal short axis is the bottom right one, and the 7 others are equidistant between them. But the important thing is here for each level, we can check, do we have the posterior wall, the posterior junction between LV and RV? Do we have the entire posterior wall of the RV? Do we have the free wall? And of course, also just as important, do we have the anterior part, and of course the anterior junction between LV and RV. When you go more basal, of course, there's no more anterior, it is actually the RVOT. So you also have to include that because it is part of the RV volume, both in diastole and systole. And we'll see that in the hands-on when you do it in a few seconds. Then we also have a tool which is called 4D auto left atrial quantification. And again, just like the RV, when we have a 4D acquisition, especially if it's transthoracic and you have the left atrium, which is easily within the area of interest, because no matter what your angle is, the LA is deep into the image that where the width is maximum, so you almost always have the LA within the field of view. Even if you're doing LV, you increase the depth and you're sure that you are always having the left atrium within the field of view. And the tool for the auto left atrial quantification is very simple. You simply place a point in the middle of the mitral valve. We will have that in the hands-on in a few seconds. But the important thing to remember is that speckle tracking is actually tracking the entire volume of the LA and giving us a butyl of the LA and giving us the instantaneous volume of the left atrium. So we see the minimum volume, the maximum volume, pre-atrial contraction volume, and endosteric volume, of course, of the left atrium. Also, it gives us the strain, the longitudinal conduit, reservoir conduit, as well as contraction strain, as well as circumferential reservoir conduit and contraction strain for the left atrium. Okay, so again, this is just an advantage of LA in terms of 4D quantification, simply because in 2D, although it is available, we even have it in the tool in the 4D AFI left atrium, but in 2D acquisition, we have to make sure from the beginning that we have the right left atrial cut plane rather than LV, because if you have the right LV, because of the angulation between the two, the geometric angulation, chances are you don't have the right acquisition of the left atrium, or at least you don't have the full length of the left atrium in the acquisition. In terms of 4D workflow, I think we can skip that because we spoke about the 4D Zoom prepare yesterday. Well, actually, I think it's a refresher for those of you who did not join last week. 4D Zoom prepare is a way to prepare the area of interest before you start acquiring 4D, so that when you activate 4D, you have the perfect cut plane in terms of cropping, as well as because it's already cropped and smaller zoomed area, then you automatically have the optimal resolution, voxel resolution, as well as frame rate. So you have the spatial resolution as well as the temporal resolution, the ideal temporal resolution. So how does it work? From a 2D, simply activate 4D zoom prepare, then you will have a zoom box. On the original 2D, as in this example, this is a 4-chamber transphageal acquisition. And as you can see from this box, they are trying to acquire the mitral valve. And having positioned this zoom box, and then we have a 90 degrees perpendicular cut plane, which is 90 degrees perpendicular on the original plane in the center, displayed on the side, and that helps us decide the thickness of the area of interest. Hence, when we activate 4D, immediately we have the right cropped zoom with optimal frame rate for that specific structure. As you can see in this example, for this mitral valve, we have 13.3 frames per second. In addition, there's also the possibility to do automatic zooming, automatic cropping and zooming of 4D structures. So for example, if you start with that same 4-chamber view for the mitral valve, and you click on mitral valve 4D zoom, immediately we'll have the same cropped area with the same type of view. If you start with a midesophageal long axis and you click on aortic valve 4D zoom, then you'll have a zoom of the aortic valve. If you start with a 2-chamber where you are seeing the left atrial appendage, then you click LA appendage 4D zoom, you will have a zoomed image of the left atrial appendage. If you start with bicaval view, click on intraatrial septum, then you'll have infasa of the intraatrial septum also in 4D. Then in addition, once you are there, you can also add additional cropping, such as the 2-click crop. 2-click crop, if we can skip to the actual image. Here you can see this is a structure that is being acquired in TE because of this is the icon for TE. And you can see this looks like a midesophageal long axis with the long axis and with 90 degrees perpendicular plane. But if you look at the volume on this side, the surface rendering on the right here, it doesn't give me much information, simply because all the walls here are within the field of view. And if I'm looking at surface, I'm looking at the outside surface, I don't see inside. So in order to see inside, I need to do some kind of cropping. And this is where 2-click crop comes in. I select where is my starting point and where is my ending point. As a result, I have a perfect view in fossa of the mitral valve from the atrial position, which is we call a surgical view. If I want to see it from the ventricular side, then I have to start my click here, as you can see live now. and then point it towards the mitral valve, then I have in-fossa again of the mitral valve, but from the ventricular side. And in this example, we are also showing in-fossa of the septum, where you can see if there's any VSDs and so forth. So this is how we can utilize two-click Rob to clip further, regardless of what kind of procedure, especially when we are doing live scanning, especially in structural heart diseases, where we are visualizing and guiding the implantation of TAVR or ASD closure devices or mitral clip or band or whatever type of structural heart procedure. As in this example, here you see the mitral clip advanced through the you can see that the clip is advanced through the mitral valve, and you can see from this motion of this mitral valve that the clip has not clasped the tips of the leaflets yet during this procedure, and you can monitor as we are doing it. And here, this is an example of an Amplatzer of an ASD closure device where only the chute that is in the left side is open, right side is still not open. You have to pull it back, of course, and then open the right side as well. 4D markers is an additional tool that is helpful when it comes to the navigation and maintaining the perspective of each anatomy, especially if you do a lot of cropping, you could easily lose perspective. But here, if you place these markers, such as aortic valve, this yellow marker, or the red marker, which you can also name it anything you want. We named it flail here in this example, and you can actually change it as you go along. Okay, so we also have lots of new developed. Sophie, can I ask you to mute, please?
All right. Any diabetic emergency?
No, sir, not feature of emergency. Hyperglycemic emergency.
All right.
So, and the headache, she said the headache has resolved, the headache has stopped.
Okay.
Yes, so I comment her. I
Please, Dr. Gilda, mute all.
Pardon?
Mute all.
Yeah, actually in the I'm on the display mode, so I'm not able to see the mute function. Thank you. Okay, so again, please try to make sure that your mic is mute. Anyway, so back to the subject of FlexiLight. FlexiLight adds additional depth information. Please don't forget that when we are looking at surface rendering, we acquire the volume of a 3D volume, right? And the fourth dimension, of course, this time when we say 4D. When we acquire the volume, we have a 3D structure that we are displaying surface rendering for, but we are displaying it on a 2D monitor. So something has to give me an idea about the depth, about the third dimension, right? And that's where we use in the initial scanning, as in this example here, this is called HD Live, where HD Live, we are using yellow for the nearer structure, bluish gray for the further structures, and we are using shadow effect. It's kind of like a street light kind of effect where you can see the shadows, and that gives me an idea about the depth perception. So how is that different from FlexiLight? FlexiLight is kind of like having a light source inside the heart itself, inside the structure itself. It's kind of like endoscopy where they have a light source. And that gives me even a better, more shadow effect that gives me that depth perception in addition. So again, we can utilize that to tell better which is near structure, which is far structure within the anatomy. You can see here in this example, this is an example mitral valve clip. And here you can see on the left, FlexiLight, the light is inside the left atrium. And this is again the opening of the and closing of the mitral valve. We are looking from the atrial side or surgical side. On the right side, this is the same view and the same angle. We are still looking from atrial side. However, the light source is changed, but the position, the light source is now inside the ventricle, and this is why we don't see it. This is why when the mitral valve is closed, there is no light. However, the light is also helping us detect the transparency of the mitral valve, which is helpful sometimes in calcifications. Here you can see in the middle, the structure is opaque. Of course, that's not calcification. That is actually the clip, the mitral clip in the middle, which is, of course, not going to be transparent. Then there's HD color, and HD color enable us to, of course, again, we are looking at surface rendering, and when there's a color jet, when there's a blood jet, that is also, we're looking at the surface rendering of it, and that can obscure the 2D. So sometimes in the past, we were able to make the color Doppler transparent. However, HD color works in a different way. HD color enable us to make only the low velocities transparent, hence appreciating the significant jets, which are usually the high velocities, as in this example. On the left, HD color is not active. On the right, HD color is active. So we made the insignificant jets transparent, hence seeing the disregarded jet, aortic AI jet very clearly is to assess the amount and the size and the significance of this aortic regurg. Even the PISA effect is shown better. Likewise, here in the mitral structure, there's no left and right. It's now inactive. You can see the blue obscuring my vision of the regurg, and now it's active. And you can see now, you can see 3 distinct regurgitant jets across this mitral valve, hence helping us visualize better. In addition, we have new tools for helping visualization during structural heart procedures, such as ViewX, where we are able actually to visualize the cath image on the echo machine, because usually in the echo machine inside the structural heart or interventional or cath lab setting, we don't see the cath image. Here we are able to slave or derive the cath image on the echo machine, so we're able to see. Of course, traditionally we are always able to see the echo image on the cath screen, the large cath pendant screen, but now we can see also the cath image on the echo machine. We also have a new fusion technology, which is called CT fusion, where we are able to fuse between CT, cardiac CT, as well as echo. And the concept is that since the planning of most complex procedures, structural heart procedures, is done actually on CT, which is the gold standard, of course, in terms of anatomy, in terms of calcification as well. Then why not bring CT into the cath lab or the interventional suite with the echo machine? And this is what CT fusion is all about. All we have to do is simply co-align between CT and echo once we make the first acquisition in echo, and then from there on, any slicing or changing in the surface rendering of the echo can be co-adjusted between the CT and the echo at the same time. They can be either overlapped or displayed side by side, as you can see in this case. Then in terms of valve quantifications, again, we also have the aortic valve quantification, where we're able to do speckle tracking of the area of the LVOT, the annulus, and the maximum area of the bulb, as you can see here in this example. We also have a tool called for the auto mitral valve quantification. Again, most vendors have an equivalent tool for mitral valve, where we do assessment, giving the area of the anterior leaflet versus the area of posterior leaflet, tenting height, tenting volume, tenting area, even the angle between the mitral annulus and the aortic annulus, for example, for tenting cases, to avoid neo LVOT obstruction. Whatever the anatomy or the cases, we can do full diagnosis of the mitral valve. Likewise, there is also a new tool for tricuspid valve, which is called for the auto tricuspid valve quantification, or TVQ. And likewise, speckle tracking works to detect the annulus, to detect the valve and the tenting and the coaptation of the leaflets, and of course the depth or the height of the coaptation, as well as the area in diastole and systole for the tricuspid valve annulus. I think now we'll go to the hands-on part of the session. If there are no questions or comments, are there any questions or comments? I'll be more than happy to answer them at this stage before we go to the hands-on.
Hi.
Hello.
Hello, hi. What we need for the acquisition for RV ejection for RV volume, only the 4-chamber view, and put our marks at the apex and the tricuspid valve as the LV quantification.
Yes, sometimes we need a targeted view of the RV. If you just want to do the RV, then you might want to tilt the probe a little bit towards the right side and acquire only a targeted RV. I think multi-slice is very helpful in this case, as I mentioned earlier, because it enables us to see the full cross-cent of the RV during the acquisition, which I hope to show in this example in a second. This is, for example, here. I'll show you in this example. So yes, I mean, it can be a full volume, including LV and RV, but it better be a targeted acquisition for the RVs, so that we can get a better frame rate and resolution for the RV. I think I have an example with a targeted acquisition for the RV, so we can show that. Otherwise, we can just show. If you give me a couple of seconds, I'll find that targeted acquisition RV. Yeah. So I'll show you both. I'll show you the general acquisition. I'll show you a targeted acquisition. This is a full acquisition. Here, this is a targeted acquisition for the RV. You can see the LV free wall is simply not there. The lateral wall of the LV, in other words, is simply out of the image. However, the full apex of the RV, the full right ventricle is in. And this is where, again, multi-slice, remember, if you go to this button here, multi-slice, then you can see the short axis views of the RV are all in. You can see from basal all the way. Let me just unzoom this a little bit here. You can see from basal, posterior junction, anterior junction, free wall, all of the RV and the apex of the RV is in. Yeah, and let me increase again so you can appreciate that better. Somehow my Zoom is drawing something on the image, Sophie. Is this something that you can help me with to reduce it, to remove it? Do you see the green line here? Thank you. Yeah, I'm getting a lot of this drawing as if I'm drawing something on the image.
Sorry, click your mouse just anywhere, unless it's
not happening, unless if it's happening.
Yeah, that is very strange.
I am somehow. Can I stop sharing my screen? Maybe it will
Try
help.
and try again.
Yes. Okay. Okay. I think this is better.
Yes.
We removed the noise, so
Sorry
I'm not
about
throwing
that.
anything by myself. Thank you. Thanks. Okay, so as you can see, again, multi-slice is helping us assess the acquisition even before we acquire. And this is a 2-bit acquisition. And look at the frame rate, 27 frames per second, which is optimal for RV. And let's do the RV quantification since we are here already. So I can just go to measure, and I can just go to volume, and here for the auto RV quantification. Of course, this software which I'm using, which is called EchoPack, this is the GE cardiac PACS solution, and this is the part of the reason of the ACE course is to educate a little bit about the use of this software in the hands-on. But what I need to mention is that as a 3D software, it is always better to have it on a proper PC rather than a laptop, because laptops always have limited graphic cards versus PC, where we could easily compromise the quality of the navigation and cropping, and even the menus sometimes may not appear well. So it's always better to have a real powerful graphic card, even if we are doing it on a quote unquote laptop. At least it has to be a very powerful graphic card type of laptop. So here you can see the landmarks. Simply, I need to place a point in the middle of the tricuspid valve from this 4-chamber view, and this image, which is 90 degrees perpendicular to it. And then I need to set landmarks for the free wall tricuspid annulus insertion, septal insertion, as well as the RV apex, which is here. And then across this line, which is where the short axis on the right is, I need to place a point where the LV meets the RV posteriorly and anteriorly, which is kind of off here. This is probably the only place where it's not well detected, and the RV free wall. And during the RV and LV volumic quantification in 4D, we always need to try to take the most compacted endocardium, not the trabeculation, because you want to measure the accurate volume. So try to go to the most compacted one. If you have a machine and you're scanning and you're doing this on the machine, so that you can get the real volume. Here you have the 4-chamber, the short axis at the white level here, which is the short axis almost between apical and mid segments. The short axis, which is almost again between mid and basal segments, and you have it on the right here. You have it at end diastole, at end systole. So here you have the 4-chamber at end diastole. I can adjust anywhere where I disagree and exaggerate or under move in or out, let's say, the endocardium wherever I see the need to by drag and drop. So I can do it for the end diastole. I can also do it for the end systole, as you can see, as I'm doing right now here. And then I can do also the same for the short axis at the white line in end diastole, as well as in systole wherever I see fit. And again, the short axis at the basal part, in diastole, and as well as systole, wherever again I see fit. Then I can just go to results, and then I will look at the again butyl of the RV. Here's inflow of the RV. Here's RVOT outflow. Here's the groove between inflow and outflow. Here's the left ventricularized septum of the RV. Of course, you can see it's bulging in because again, it's a normal RV. It's not a dilated RV or an overpressured RV, then you can see here end-diastolic volume, end-systolic volume, ejection fraction, stroke volume, diameters at base, at mid, length, TAPSE, and even fractional area change for the RV. Most importantly, again, now we have for the first time the volume, end-diastolic and end-systolic volume of the RV. And of course, this is a validated tool. So this is one example in terms of RV. Let's go to the image where we have the LV, and we can do the full for the LV quantification, including LV strain. So here, this is another acquisition, and we can see, we will be able to see in this acquisition that actually this is optimal for both LV quantification as well as right ventricular quantification. How we can see that? Multi-slice, and now you can see the short axis views. And let me just zoom that a little bit. And here you can see all the rings of the LV from base all the way to apex. Lateral wall is in, posterior wall, anterior lateral, anterior septal, septum. Also for the RV, it's actually all in. You can see posterior wall, free wall, anterior junction, posterior junction of the RV. So the full RV is in, RV inflow, RV OT, and you can even see all the way to the apex. We have all these segments, maybe a little bit at the top of the apex, part of the anterior and part of the free wall of the RV is not in. Other than that, it's almost all in. But don't forget, this was just one acquisition. So, and I think this was more targeted for LV. So again, to measure for the auto LV quantification, we can just go to measure. We can go to volume, and here we have for the auto LVQ. And again, we just need to, this is auto aligning or aligning of the views. We are okay with the aligning. We can just go to end-diastolic volume. And here again, the machine is asking us to place at end-diastole, apex, and mid-base. So here's the mid-base. You can practice this and you will get a very good idea where you need to place your markers. You can also use the next cycle. As you can see, here's the cooptation. So you need to be a little bit in the center, in the lower part of the cooptation for base, and a point at the apex. Because the point here needs to be also near the base of the annular insertion. And here is the apex endocardium. Now you can see the volume calculation. Because if you place this point too high, then you will not drop here to the annulus point. The algorithm will not, or the speckle tracking will not drop exactly to the base. So now that we have this automated speckle tracking, again, as I mentioned, there's always a step where you have to validate, you have to accept it yourself, or you have to make changes yourself. One of the first things I can see here in this image that needs to be changed, of course, including the LVOT, because that is part of the LV volume. Then here in 3-chamber, you can see this is not included of the anterior, the septal, the apical septal segment. So this needs to be included. Sorry, I have a flight. Okay, so I included that, and you can check also the short axis views. What are these short axis views? You have the top one, which is a short axis at this yellow level. You have the middle one, which is short axis at the white dotted line level, and you have the bottom one, which is at the green dotted line. The important thing is that I can see here all this short axis, and I can see this is all trabeculation. So again, I can go to the most compacted endocardium in each one of these short axis levels. Here, I can also exaggerate this. Here, I can also exaggerate this for the endocardium. Now I have a much better idea about the end-diastolic volume. Then I can go next to end-systolic volume. And you can see EDV, I'm sorry, end-diastolic volume has already been calculated. Now I need to place again a point at the base and a point at the apex. And again, the speckle tracking has worked for this volume in systole, at end systole. And you can see that from the ECG here in the bottom, this is the end systolic phase. Again, just like we did for the end diastole, I can just make the adjustments here very quickly for the short axis, so that I go to the most compacted endocardium and make a more accurate measurement of the end systolic volume. So now my ESV is 74 ml, ejection fraction is 53%. Now I can go to volume waveform, and it will give me an instantaneous volume calculation from end diastole to end systole, because it will track this LV throughout the cardiac cycle. In a few seconds, I will also be able to, so here you can see the instantaneous volume in diastole, in systole, rapid filling during early diastole, diastasis, rapid filling again during atrial contraction. And again, you can check the quality of the speckle tracking throughout the cardiac cycle. It looks very good, and you can simply have confidence in this data. And as we mentioned last time, this correlates more, the 4D volumic quantification of the LV correlates more to the gold standard MR than for example, 2D Simpson biplane or any other 2D measurement of volumes. Then next step, I'll go to LV mass, and you can see here, now the speckle tracking has tracked the epicardium of the LV. And I need to make sure about one thing here. I want to include the full epicardium, but I do not want to include the pericardium, because pericardium does not contract. Okay, so it will underestimate the strain values. So now we'll go to 4D strain results, and just like we tracked the epicardium, the epicardium in diastole, now we are tracking the epicardium in systole, endocardium and epicardium in systole. So if I'm happy with this, I will go to 4D strain results. As you can see, it's all more or less automated. However, it always allows me to check and validate, do I accept and appreciate these measurements, or do I not accept these measurements? Okay. Now that we have taken the region of interest, now it will do 4D strain, and 4D strain takes a few seconds. Yes? Any question? Okay. All right, so now we have the values. We have the 4D strain, so I can just go to end the systole, and now you will have the longitudinal strain for each segment and the global average for the modified 17 segments of longitudinal strain. This is longitudinal strain, so we can also go to circumferential strain, and it will also give us the strain curve for each segment circumferentially and the global circumferential strain. Area strain, which is again more or less a summation of both, and then you have the radial strain, which is the inverted strain, of course, which is the positive strain, and of course it's always much higher in value than the normal strain. Then there's even a rotation where we can have the rotation of the basal ring, rotation of the mid ring, and average rotation, of course, because the different segments have different rotation during the cardiac cycle, even at each short axis level or ring. But anyway, and we also have the apical, the average rotation of the apical ring, and then the twist, which is the difference between the apical and the basal rings, which is the probably the most valuable value of rotation, let's say, for LV. So if I'm happy with this, I will just approve or cancel. I will actually cancel in this case. And then from the same data set, we can actually do 4D auto left atrial quantification, because as I mentioned, here you can see the left atrium is all within the field of view from all the apical views. Of course, in the short axis, it's not showing because these slices are here, but it doesn't matter. I can just go to 4D auto left atrial quantification, and you will see now the processing will start, and it will give me the 3 apical views: 4-chamber, 2-chamber, 3-chamber. And you will see now that the actual the shortening or foreshortening doesn't really matter, because here we don't have a proper, for example, if the position is here, we don't have a proper 2-chamber, 3-chamber. It doesn't matter. What we need to do is follow the pictogram, and it's telling me to position this point and the line in the middle of the mitral valve from 4-chamber perspective, from 2-chamber perspective, as well from 3-chamber perspective. And once I've done that, then I don't need to do anything else. I can just go to review, and the speckle tracking will start for this left atrium. Yes. Yes. Okay, so Dr. Edson, thank you. Okay, so if I go to end diastole, now I can validate what I see and accept or adjust what I see. So if I go to end diastole, you can see here, this is of course end ventricular diastole, which is more or less end systole for the left atrium. So again, I can make adjustments anywhere I want. I need to make sure that I include the full walls of the left atrium, the maximum, and of course, just like in 2D, we should try to get the maximum or the most outer perimeter of the left atrium, or try to exaggerate, in other words, as much as possible. So that was end diastole. Then I can go to end systole again, which is the actual end diastole of the LA, or the maximum volume of the LA. And again, you can see here, I can make adjustments for this speckle tracking to make sure that it includes the full volume and the detecting the best endocardial. Don't forget, we're gonna do strain. So we need to make sure that we are at the endocardial level and not inwards or not outwards. Then pre-A and pre-atrial contraction, again, try to make sure to include it all everywhere. Once you do that, then you can go to results, and then you see running butyl of the LA, instantaneous volume, minimum volume, which is 29 ml, maximum volume 72 ml, and then pre-atrial contraction volume, which is 45 ml, and giving us ejection volume, ejection fraction, and then again strain curves. And if I click on strain, now you see this curve is for the volume. But if I go and click on strain, then this is the curve for longitudinal strain. And again, you can see reservoir strain, conduit strain, contraction strain. This is a longitudinal conduit, reservoir conduit contraction. And then again, if I go click here, this is the curve for the entire strain curve for circumferential. And again, you can see here the value for reservoir strain, conduit strain, and contraction strain as well. And usually the reservoir strain is the summation of the absolute value of both the conduit and contraction strain. So 18 plus minus 18 plus minus 17 equals minus 35, absolute value is 35. That is usually the reservoir strain. Questions about LA strain and all chamber quantifications? We covered left atrial quantification, we covered RV quantification, we covered LV quantification and LV strain as well, all in 4D, of course. So any questions before we go to valve quantifications? Yes?
So how much this LA strain is validated for assessment of left atrial pressure? Because, for instance, I saw the measure we are using, for example, during acute MI to measure LV filling pressure, it's not so accurate, actually, not so sensitive to detect LV filling pressure. But LA strain is nice, especially if you have number less than 15%. As you said, the LA strain minus 30, 35 is normal, but the cutoff of 15, I saw it might represent a good measure for high left LV filling pressure. So what do you think of this? Is it validated for measurement of pressure? Filling pressure?
I'm not sure about the filling pressure. I mean, it is validated for volume assessment, of course, but for filling pressure, to be honest, I'm not sure. But we can share. We have, if you go to the Vivid Club, this is www.vividecoclub.net. Actually, it's not .com, it's .net. We have all the literature material for validating all these tools, LA quantification, RV quantification. They're all validated, of course. We don't provide any solution unless it is validated, unless there is literature to support it. So we have a lot of literature supported, but actual values, I mean, cutoff values, I think it's within the ESC guidelines, maybe, but not. It's not for us to. I mean, we're not even allowed to talk about values as a company. It is the literature and the ESC and the American Society of Eco guidelines as well that will decide the values. So to be honest, I'm not sure, but I'm happy to hear your experience from it, and what do you think is the absolute value. And if anybody has any input, we are more than happy to share it.
The American Society of Cardiology, there is one article or one large study that they validate from 35 to 24. It is like impaired relaxation. From 24 to 19%, it is pseudo-normal pattern, and less than 19, it represents restrictive pattern. But this is not validated in the guidelines. It is only studies only.
Okay, great. Thank you for sharing that, Doctor. Any other questions or comments before we go to
other question regarding RV and LVQ. So we are using this during TE. Is it validated during TE or only for transthoracic? I mean, the way you measure the ejection fraction and others. I'm using it during TE. Is it validated for TE or it is for short and not validated? What do you think?
No, it's validated for both, for TE and for transthoracic as well.
Okay.
It's available for both, yes. Thanks. Any other question or comments? Please, we would love for this session to be as interactive as possible. So if any question or comment anytime, please do stop me. We are more than happy to hear from you at any time during this session.
We have a question from Fatima Arshi.
Yes.
Yep.
Yes. Yeah, I'm the technologist. I just want to asking about the acquisition of the RV. You know what? Whenever I am going from the RV volume for the acquisition, we have to do for the 2D to set to check our RVPD wall and full acquisition. When I will put the multi-slice, that time I need to be rechange from the acquisition because the RVPD wall is sometimes cutting. When I will put the multi-slice, then I will do to the sample volume is increased by the frame rate will be increased. Then I will do again acquisition with the multi-slice. So it is not possible we can tilt the images with the multiple slice.
With multi-slice here, this is kind of like CT slicing, you know. So whatever you have within the volume is what you have. Tilting during live scanning, you can tilt, and the multi-slice will tilt. So for example, here at this position, if your probe is positioned at 4 chamber, just a simple tilting will show me more of the free wall of the RV, less of the lateral wall of the LV, and that's perfect for RV acquisition. So yes, you can do that during live acquisition, but the moment you tilt, the moment you're happy with it, then you can acquire. The moment you acquire, then that's it. You cannot change anything more about the actual volume.
Okay, because usually when I will using even those in the sometimes with the RVPD wall, I cannot see it with with this multiple slice, then I need to be readjustment my views according to this multiple slice, and then I will able to do take the RV volume.
You mean you are displaying this display, by the way, is something that you can change from the layout and by clicking multi-slice during live scanning. So even during live scanning, you can actually select multi-slice and show this multi-slice. During live scanning, while showing this multi-slice, you can select the size of the volume. So you can make the volume bigger or smaller. And now, if you need multi-beat, you can activate or deactivate multi-beat during live scanning. The moment you see a happy acquisition, you are happy with the acquisition, then you can store this data set, this volume data set, then it's ideal.
Okay.
I hope.
The other things, yeah, I understand your point. The other thing, sorry, when I'm going for the take the volume, and after the volume, then we see the volume that they give me the value and everything. But you know, the when I will going for the acquire images, it will be is by the P2 because there is no option for the image store. So I can show the live acquisition. How can I will do the image store with the live?
No, I'm sorry, I couldn't hear you because your voice was cutting during the middle. So you're saying during acquisition, what happens?
The RV volume. I'm just asking you the RV volume and the LA volume, even the LA volume.
Yes.
When I will taking that, but I need to be the live when I will going from the image store. It will be showing the still images. How I can be do yani ke in the live video? Live
If you
full.
go to the if you go to the stored image,
Yes.
it will not be a still image.
No, it's because there's no highlighted in the image store. That's why I just put the P2. The P2, this is the whole scan. It will be the acquire. It not is going for the live session.
No, I'm sorry. I'm not sure if I'm following. What do you mean? What is P2? What do you mean by P2?
P2, it is the image store, the another option for the image store. Whenever the image, whenever we are not acquire the images, maybe we are not able to store the images by the image store. This button is not highlighted, so we are just using the P2. But whenever you are using the P2, that was the
I'm
image
sorry.
is showing
I'm
the
sorry.
freeze.
Why would you not be able to store image?
I
What
don't
do you
know
mean it's
because
not highlighted?
yeah, it's the button. The button is just not highlighted. The light is not highlighted.
I think we can send an application specialist. This is probably something has to do with the because you should be able to acquire, and P2 is programmable. It's something that you program, so it can be programmed to store static image. So maybe that's why you are storing static image. If you want, you can also program it to acquire a loop. And you can also select if you want it retrospective or prospective. It is something that is flexible in terms of the digital acquisition. But that's a different. I mean, that's something we can configure on the machine itself. But usually, just image store itself should be active when you are doing 4D, and you don't need to use alternative buttons.
Okay.
And it will store a loop. Yeah.
Oh, thank you.
Yep.
I can just mention, Fatima, if you don't mind just sending me a message in chat with your contact details and where you are based, and we'll get someone to follow up with you if that's okay.
Yeah, it's okay. I'm from King Faisal Hospital, Riyadh.
Okay.
And then I will the some details. I'm the technologist, and now also the written. I will be in the giving you then the written.
That'll be fantastic.
Okay.
Thank you.
I'll make sure our local app visits you as soon as possible.
Thank you very much, Joel. Thank you.
He's with us on the call, so he can hear this.
Thank you.
Thanks. Any other questions or comments before we do the valve quantifications since we are here?
What is the meaning of 4D clarity button?
4D clarity button. Do you see it now?
No, not here, but it appear in the machine there is an option for D clarity.
Oh, okay, I see it here. It's a very good question. To be honest, I'm not sure if I can answer it. I think it's one of our application team. Any of the application is here that can maybe clarify what it's doing. I think it's a smoothing of the 4D. It's a smoothing. It's a speckle. It's a speckle smoothing of the 4D. So when 4D clarity is maximum, you can see the 4D is more smooth and homogeneous. When 4D is not, then it's when it's low, then it's more grainy speckles of the 4D. It's just like I believe it's just like the UD clarity. The UD clarity is the ultra definition clarity, and this is for 2D grayscale, making it also smooth versus contrasty.
Okay. Yeah. I have only one last question, please. I have our institution have 4 GE machines, okay, but we have Tomtec, not EcoBack, okay.
Okay.
So we send the technicians, technologists send all 4D to the Tomtec. And we took all the measurements from Tomtec. I want to ask if there is the validity of Tomtec from GE machines. It is valid.
Yeah.
It is valid.
Yes, it is valid. First of all, the technician, if they do the measurements on the Eco machine and they transfer it to Tomtec, part of the, because Tomtec uses DICOM language, and part of the DICOM transferred data, which is images, there's also DICOM SR, the DICOM structured report, which is the measurement that will also be labeled and
I mean to do measurement. I mean to do measurement on Tomtec.
Yes. But doing the measurement,
they are sending raw data only.
Yes, yes. Even on the Tomtec, because the Tomtec is a DICOM, uses the DICOM language. Any PACS network uses DICOM. So yes, the measurements on DICOM are validated, and the important thing is not to lose the image quality from the machine to the PACS, and which is rarely the case. In most cases, the images coming from raw data from the Vivids is optimal also on any PACS quote unquote DICOM network. So the DICOM images are okay, and they are validated. Of course, DICOM is the standard of medical imaging where all the measurements are done. There's also always growth in that field. There's HEMIS, which is Hospital Enterprise Management Solutions, I think, Congress, which is held every year. They have what they call connectathons, where they try to connect between different vendor machines to different vendor PACS solutions. And I think one of the most important outcomes of this is not only DICOM, because DICOM has been standardized for a long time, but now you have the ability to crop and navigate 4D data sets. So if you acquire 4D on the Vivid machine, you can send it to Tomtec, and you'll be able to crop and navigate, even quantify on a Tomtec, and vice versa from any vendor to the Eco Pack plugin on Centricity and on Viewpoint, and even on third party, because Eco Pack plugin is available on even third party PACS solutions. So yes, I mean, it is validated, to answer your question.
Thank you.
Mr. Jawdat, Mr. Jawdat, for assessment of LVQ, suppose you acquire image and then you get frame rate, like let's say 14. It's not a multi-beat option, only single beat, but you get frame rate 14. Is that enough? Is this the best way to assess LVQ, or better to choose multi-beat if you get 14, for example, frame rate? And for example,
Yes.
if you are free to increase the frame rate, is it appropriate to increase to like 20, or better to keep 14? Which one is the best? Which the best option?
Very good question. Thank you very much. Yes, during the acquisition, you are at liberty, or you have the flexibility to increase the frame rate manually. But of course, this will be on a compromise on the resolution. So when we are doing speckle tracking and volumic measurements and quantifications, then you don't really need that much frame rate if you're just doing volume quantification. So 14 is more than enough for LV quantification, because you will get here. I will show you in this example. I think the top image here, the frame rate is probably no more than 12.8, and we can still do for the LV quantification, because despite we have 3 ECG cycles, there's no triggering. So this was a single beat. There's no multi-beat or stitching or anything. So we are able to do for the LV quantification. We are able to accurately, the speckle tracking is able to detect it. The only thing, it will not accept anything less than 10, I think, or 12, because if it's less than 10, then speckle tracking will not work well, because if you have a speckle one frame and then the next frame is far away in time, then by the time we scan the next frame, this speckle has moved so much and changed in shape so much that the speckle tracking is not able to detect it. And then you have one moment the mitral valve is open, next moment it's closed. So you don't see when it has a close, when is the diastole and end systole also in terms of assessment. So frame rate is important, but it's not too important, especially for volumic quantification. If I'm doing LVQ, RVQ, I think RVQ requires 16 or 15 frames per second minimum. So you don't need much more than that. But if you are doing strain quantification, then you need a lot of speckle. Then you need to have much higher frame rate. So if you're only doing volume, 14 is more than enough to answer the question.
Thank you. Thank you very much.
Thank you. Great.
So
any other questions? Yes.
So multi-beat acquisition is good for structural for structure only, but not good for LV function.
No, it is good for strain only, but for structural heart, no. For structural heart, you cannot. Most likely, you're not at liberty to use multi-beat, because you want it real time. You want it live. You are.
The picture resolution will be less if I use the multi-beats.
Yeah, but for structural, no, spatial resolution will be better with multi-beat. But the point is, for structural heart, usually you are using transesophageal. So already you have an ideal resolution, right? So you already have a best resolution in the first place, whether it's 2D or 3D. So you don't need to compromise frame rate. You can increase frame rate manually, and the resolution is still very good.
Then the best acquisition for volume is full volume.
No, full volume is only. Fadal.
Full volume, yes. Please. The best acquisition for LV functions is full volume, or it's not related?
You mean single beat or multi-beat, or full volume in terms of?
Full volume. Full volume, in terms of full volume.
Yeah. The best acquisition, look, the best acquisition for any structure, for any view is the acquisition that includes the full anatomy that I'm trying to scan. So for example, let me just exit this measurement. Okay, so for example, if I start here with a 2D, I don't know what my mouse is doing, sorry. Okay, so for example, here I have this 4-chamber, just a normal 4-chamber view, right?
Okay.
I'm sorry, I'm just waiting for my cursor to work. Okay, so here I have a 4-chamber view, right? What do I want to do with this 4-chamber view? Am I trying to acquire LV or LA or RV, right? So if I'm focusing on LA, I can make this width much smaller to include only the LA. So once I make this width smaller, or I can use 4D zoom prepare, which we mentioned earlier, where I have a zoom box around the LA or mitral or any structure, and then I have it one direction, the other direction, which is 90 degrees, and then I acquire. Then I can decide how is my frame rate, is it sufficient or not if I'm doing a specific quantification. If I'm doing LV volume, then all I need is 12 volumes per second. If I'm doing LA strain, then I need a little bit more. Don't forget that the LA is a bit far, right? So the speckle will be more diffused. So I need that higher resolution for it. If I'm doing RV, then I need to focus on RV, and then I need to make sure. And this is where I'm saying, you know, during the acquisition, Flexi multi-slice is very helpful to decide, do I have the right volume for the right data set? Here, this is a full volume, huge volume, LV and RV. Usually, I don't need to acquire all LV and RV all at the same time. This is why the frame rate is compromised. Even the resolution is somewhat compromised. This is why the frame rate is only 12.8 or 13 volumes, but this is the maximum volume almost. It's almost like a 90 degrees by 90 degrees. Does that make sense or answer your question?
Yes, yes. Thank you.
Mr. Jawdat, maybe I'm interrupting you too much. So it's
My
okay?
pleasure. My pleasure. My pleasure.
Thank you, sir. I have problem with the assessment of mitral valve, mitral ring area. You know, sometimes we need to assess mitral regurgitation. So by volumetric method, how much the volume of regurgitation. So I'm using the 3D annulus area. So yeah, either I'm using MVQ, you know, mitral valve, MVQ, the automated. So you will get automated assessment of they'll give you the mitral valve area. But usually with this method, the mitral, the ring area or the mitral ring area will be odd number. You get number like 13, 14. But if I'm using this, the large volume here, like LVQ, I'm using flex slice at the annulus, you will get proper number, like reasonable number. You'll get 6, 5, 6, 7 mitral valve, mitral ring area, so that you can use it for assessment of, you know, mitral regurgitation by the volumetric method. So I don't know why if I use the MVQ, I know they are going to talk about this subject, but later. But I'm using the flex slice here. If I use this large volume in the LVQ to assess the mitral area, the mitral ring area at the using flex slice, it's more accurate than MVQ method, automated method. I don't know why the number there always it come with me odd number. I don't know why. So do you have any answer for that?
So you're using the flexi slice or multi-slice.
Flex slice for here. And this in the LVQ, you know, I will take the large volume which are using for LVQ. So yeah. So if I use the flexi slice option to assess the mitral ring, then the area assessment will be very accurate, very nice. But if I'm using the MVQ, the mitral valve MVQ method, which is you will get automated, you know, anterior leaflet length, tenting height, many things you will get, including the mitral annulus area. The mitral annulus area there will be, the number will be odd usually. Number is not you know, going with the usual method. The number will not be reasonable. It will be like 10, more than 10. So it's not appropriate always. I don't know why this method not accurate for assessment of the annulus area, which I needed many times actually. You know, for assessment of mitral regurgitation by continuity, it's very long. You know, it will take a long time. I'm using, for example, aortic LVOT area, using 3D LVOT area, and then the VTI and the LVOT. And I'm using mitral ring area and the VTI in the mitral annulus. So I saw the best way is flex slice at the annulus level. But again, we have other method, which is the mitral valve, use mitral valve MVQ. The mitral area, it will not be, the ring area will not be very accurate there.
Yes, so you are using basically this
Yes.
measurement to measure
Yes.
the annulus area, the mitral
Yes,
valve annulus area.
Yes.
And you're saying when you do 4D, it is not as accurate as here.
Yes, true.
So
I don't know
what
is my defect there in the MVQ method.
the
tracing is okay. I mean, you trace the mitral. I mean, the setting point is easy. You can't set the point. It is 5-6 point. You will set it. But the annulus area, it will not be accurately assessed.
So here's generics. I'm sorry, my mouse is really acting weird. I'm not even able to make this tracing properly.
But
because I have
this is flexi slice, right? Flexi slice, yes.
Yes, I'm just trying to use flexi slice just to measure this image. Sorry, again, my mouse is just going all over the place.
So here you'll get 5.86, for example, which is a reasonable number. But there you will get, for example, 12, 10.
You get 5.6 for the annulus area?
Yes. How much you'll get here, for example? Like if you use the diameter, let's say diameter is 3, so 3 by 3 by 0.78, 3 by 3 by 0.785, it will be like it will be 7, for example. So the number, for example, the annulus diameter in the 4-chamber view or 2-chamber, like 3 centimeters. So 3 by 3 by 0.785, it will be 7 square centimeter, which is the reasonable, the average annulus. But if you do it in the MVQ, you will get number like 10, 8, too much, big number. So I don't know why there it will be the number usually odd, which not appropriate to be used. Here is better actually, but here also, you know, the resolution is not so good. To be sure, yeah.
Yeah. I'm just trying to do this on my Echo Pack, but again, my mouse is acting weird. And I think usually Zoom takes a toll on the graphic card. So this is why, to be honest, I'm suffering right now to get the best images for this, or to get to conduct the actual measurements here. So let me just try to jump in here. Okay, so let's go to Flexi Slice. Oh, sorry, that's Flexi Light.
Flexi Light is good in BFO. Very nice. You will see the BFO.
Oh, okay, that's great to know.
Yes, it's very nice. You will see the defect.
Thank you. That's a very good pointer.
Yeah, you will see in 3D the BFO. Very nice. You will see by using Flexi Light.
Okay,
that's
so
good.
Maybe we can use this.
It's not allowed to measure in the 3D, right? It's allowed because we are not sure. You have to measure in the 2D.
You can measure it in 3D, yes.
Mm.
Like I said earlier, you just need to be in FASA as much as possible in order to measure it accurately in 3D. So no, I'm sorry, I'm not able to do it with the zoom and with my current mouse. It's just going all over the place.
So for example, here you'll get number 7, 6.5. But
Yeah.
another method, you will get higher number, too much higher number. The MVQ. MVQ automated method.
Yes. Let's just do the MVQ here. So measure valve for the auto MVQ.
Hmm.
Okay, so here's the pictogram guidance. So we need to set the landmarks for the insertion points. You can zoom this. So here's the posterior insertion point. Here's the anterior. And here's the coaptation. And here's the aortic valve. Okay, so here's the mitral valve and the results. Annulus area in 3D, it's 9.5 square centimeters.
This is wrong. This is wrong. That's my question. This is wrong number. Cannot be the annulus in this page cannot be 9.5. Too much. It should not be more than 7. That's
yeah.
And even here, if you see the module here, it's outside the ring.
Yes.
The annulus. So
yes.
I don't know. There is
yes.
a problem with this technique.
I think we just need to be careful with this landmarks here. For example, these points, we need to make sure that they are not protruding beyond the insertion points. Here, for example, the posterior is here, the anterior is at this edge. I think the anterior side is the most exaggerated, maybe with this automated tool. And during the check here, we can actually, I think we can adjust this. We can only adjust it from the scallops. So if you go to the scallops, we can make the adjustments in anywhere where we don't see it fit, especially for the anterior side. Because I think that's where the most exaggeration is, if that's what you are referring to. And here, likewise, for the posterior as well. For example, here, this posterior side is exaggerated. If that's what you are measuring in 2D. But just like here, it's shown as 7. Just like the volumic area, when we said 4D tends to exaggerate it. So maybe that's I'm not sure about the literature, but maybe it could be just as validated in terms of 4D. But you are right. I mean, here you can see this is still LA. So if it is LA, then it's not part of the annulus itself. If it's LA wall that you are speckle tracking, because here if you change this to include more, you are speckle tracking the LA wall itself, not the annulus. So yes, you have a point there.
Thank you.
Thanks. Okay, so we did the MVQ. There's also the right ventricular quantification. We can also do it from here. We did the mitral valve, and here's the tricuspid valve quantification, where we can just do it. on the same data set. I believe the frame rate might be too low, but anyway, I will try to see if it works here, because remember, this was a huge volume taken. So all we need is a point in the middle of the tricuspid valve, set landmarks, and likewise mark the anterior insertion in the free wall and the posterior, free wall insertion, septum, coaptation. And here again, we have the tricuspid valve. So on the right, it's ventricular side, atrial side. On the left, it's ventricular side. You can see the tips are protruding towards the, or the coaptation protruding towards the RV. And here, the coded or color-coded points. This is the septum. The orange is the free wall. The green is the anterior. The purple is the posterior side. And here are the results. Let's see in terms of values for the annulus area in 2D, 7.9 square centimeters, 10.4 perimeter, and all the other values for the RV, annulus, and leaflets. So this is quickly how you can actually do the RV quantification, and of course, more and more validation is happening. Yes. Okay, so I promised since last time we'll try to make it as light as possible. Are there any other questions or comments? Before we, thank you very much, great feedback. Are there any other questions or comments? We'll be happy to answer them before we close this session.
The accurate measurements for the mitral valve and or tricuspid valve or even aortic valve is from TE, not from transthoracic echocardiography. So the numbers or the measurements or the reference values from transthoracic echo is validated if we have good picture.
I mean, yes, the method is validated. There has been a lot of literature and studies. We have white papers for each one of these tools validating the use transthoracic and transesophageal. The only tool that is not, for example, aortic valve quantification is only validated for transesophageal. It's not validated and not available as a result, of course, on the echo machines on the transthoracic acquisitions. But the rest are all validated, and there are white papers supporting that use in transthoracic and transesophageal. I think left atrial quantification is not possible in TE, and aortic valve quantification is not possible in transthoracic. These are the only two, but the rest are validated for both. So RV is validated for transesophageal and transthoracic. LV volume is validated for transesophageal and transthoracic, but not the strain. And also mitral valve and tricuspid valve are validated for both transesophageal and transthoracic as well.
So for tricuspid valve, transthoracic is better actually. Assessment of 3D assessment of tricuspid valve by 3D better from transthoracic than transesophageal. Transesophageal very difficult to assess the tricuspid valve.
Especially to acquire.
The acquisition is difficult. The valve is thin. It's below the sternum. The image is very difficult, but transthoracic is better.
Great, thanks for the feedback. That's very good to have this feedback. Okay, any questions or comments? Okay, we know you all have very long days and very long evenings, and we really appreciate. Thank you very much for joining this session and making this a very interactive session. Really appreciate your input and questions and comments. And see you next week for the strain dedicated advanced or in-depth, let's say, of strain quantification. We will talk about both tissue Doppler as well as speckle tracking, strain and quantification, and the use of all in the or integrating them into the routine echo in the future. So thanks again for this very, very interactive session. Really appreciate the feedback and the input and the involvement from everyone, engagement. And thank you for your patience again. We tried to make it at 90 minutes. We had a lot of comments. Let's try to make it as short as possible. But we went a little bit over. But again, it was a very interactive session. So thanks again. Have a lovely evening, everyone, and really appreciate your involvement. And I think that's all we wanted to share for today.
Thank you for the overview. Thank you very much.
Thanks.
Thank you, Judat. Thank you, everyone.
Thanks. Bye-bye, everyone.